Mr. Stomach can be defined as the most extensible part of the GIT. But if you take too much stress, it is a victim of acidity. So please don't take too much stress. You need to go easy on yourself. All the best for the abdomen series. Oh, all the best. Hello. I hope you guys had fun with the spleen, and now we move on to the stomach. Now I want to mention right here that whenever you think of the stomach, we always perceive it in a two-dimensional shape. But if you observe carefully in this three-dimensional figure, you'll see that the long axis of the stomach is not vertical. It goes forwards and downwards and from the left to the right towards the midline, and by the time you reach the pyloric end, it starts going backwards and upwards again and more towards the right to meet the duodenum, which is a retroperitoneal organ. The stomach, however, does enjoy mobility except at its upper and lower ends. Let's try to find out some more things about it. Now we've already discussed the proforma of an abdominal organ, so I'm not going to go through it, but just take a few seconds and understand what all we shall be discussing it under.
Okay, introduction. The stomach is derived from the Greek word gaster. That's how we get gastric acid, gastric carcinoma. Another Latin word for it is venter. If you want to define the stomach, you can say it is the most distensible part of the gastrointestinal tract. Okay, let's talk about the functions. Okay, function number one is that it acts as a reservoir of food. After we eat the food, the solid food is converted into a semi-solid consistency known as chyme. And this takes about 2 hours, and then slowly the chyme is released into the next part, that is the duodenum. And this is regulated by the presence of what is known as the pyloric sphincter. So I want you to understand that the process of digestion may begin in the stomach, but it's not completed over there. There's a slight breaking down of complex molecules into simpler ones by the presence of hydrochloric acid. And this is secreted by the parietal cells of the stomach mucosa. Not only does this help in breaking the complex molecules into simpler ones, it also helps in disinfection or killing the bacteria in the stomach wall. Along with hydrochloric acid, the parietal cells also secrete the intrinsic factor of calcium. Now, this is an important factor that is necessary in the absorption of vitamin B12, which occurs in the ileum. Okay? So, it acts as a reservoir of food. It converts the solid consistency into the semi-solid chyme, which is regulated and delivered slowly to the duodenum with the help of the pyloric sphincter. It secretes hydrochloric acid, which helps in the initial part of digestion of breaking complex molecules into simpler ones, as well as helps to eliminate the bacteria in the stomach. And the parietal cells also secrete the intrinsic factor of calcium required for the absorption of B12 in the ileum. Okay, next let's discuss the location and the extent of the stomach. So if you were to use the 9 quadrants, then the stomach lies in the epigastric, the left hypochondriac, as well as the umbilical quadrants. A part of it also extends into the left lumbar. Now, if you want to exactly pinpoint both the ends of the stomach, then you can find out the cardiac end. And I've already mentioned this in the previous lecture by finding a point 2.5 centimeters to the left of the mid-sternal line that lies at the lower border of T11 vertebra. It might probably come somewhere over here. Lower border of the T11 vertebra. If you trace this plane anteriorly, it passes through the tip of the 7th costal cartilage. The other end, that is the pyloric end, can be drawn 1.25 centimeters to the right hand side of the transpyloric plane that passes through the lower border of the L1 vertebra. Once again, 1.25 centimeters to the right hand side of the mid-sternal line at the transpyloric plane. Connect both these points, you get your lesser curvature roughly, and so this is where the stomach lies. Okay, morphology. First let us talk about the shape of the stomach. Now the shape of the stomach is typically J-shaped. That's the most common representation of the stomach. Usually when you draw it 2 dimensional, you draw it like this. However, the shape is variable. It could sometimes be a little more horizontal, so that would go somewhere like this. It would be even more horizontal and thinner, in which case it is known as the steer horn kind of a stomach, because it resembles a steer horn. Okay. Then this variety is commonly seen in short and obese people. On the contrary, in tall and thin people, the stomach will take a more vertical or even an inverted L-shaped appearance. So it would be something like this. Because it's the different kind of variations that you might see in the shape of the stomach. Now, you also need to know that in the same individual, the stomach may vary in shape depending upon the amount of food present in it, whether the person is fasting, whether the person is on a certain kind of a diet. Sometimes if you are on a hypocaloric diet and you're eating really less, then the stomach automatically starts shrinking in size. In fact, that is one of the characteristic features of the stomach, that its walls have an elastic nature, because of which it shrinks in size, which is the reason why you might probably not be able to eat as much as you used to when you start getting on a diet. Similarly, sometimes if you start to gain weight and you start eating more, you'll see that the capacity of food intake increases because the stomach starts literally getting bigger in size. So what you need to understand is the stomach is an inconsistent shaped organ even in the same individual. Now let us talk about the capacity of the stomach. At birth, the capacity of the stomach is as low as 30 ml. At puberty, it reaches about 1 liter, and in adult life, though variable, it might range from 1.5 to 2 liters. Do note that the capacity
keeps on changing as well according to the intake.
Okay, now let's talk about the measurements. The only thing that can be considered as a constant in the stomach is the stomach length, which is 25 centimeters. Okay, now let us talk about the external features of the stomach. The stomach presents two ends, two curvatures, two surfaces, and two notches. And it can further be subdivided into two parts, each of which can further be subdivided into two parts. Okay, let's first talk about the ends. The ends are the cardiac end and the pyloric end. Now the cardiac end is this part. It is the point where the esophagus meets the cardiac portion of the stomach. As mentioned before, the cardiac end lies at a plane that passes through the lower border of T11 vertebra, and it lies at a point 2.5 centimeters to the left of the midsternal line. If you trace this plane anteriorly, it ends up passing through the tip of the 7th costal cartilage. The pyloric end, on the other hand, is the end after which the stomach continues as the first part of the duodenum. This point, as mentioned before, lies about 1.25 centimeters to the right side of the midsternal line at the transpyloric plane, which passes, when traced posteriorly, to the lower border of the L1 vertebra, and if traced anteriorly, through the tip of the 9th costal cartilage. The curvatures are known as the lesser curvature and the greater curvature. Also remember that the lesser curvature gives attachment to a double fold of peritoneum that is known as the lesser omentum, while the greater curvature gives attachment to a double fold of peritoneum that is known as the greater omentum. The greater omentum swoops down like this, and we are going to talk too much details because we discussed that in peritoneum. And the lesser omentum is like a double fold of peritoneum that essentially is connected to the liver. Okay? Okay, now let's discuss the surfaces. Now technically, as I mentioned in the beginning of the lecture, the stomach in a three-dimensional orientation has its anterior surface also facing slightly superiorly, right? So hence it's also known as the anterior-superior surface. So this is your anterior-superior surface, and behind both is your posterior-inferior surface. We'll discuss more about the surfaces when we speak about the relations, right? Okay, next we speak about the notches. So you have the cardiac notch. The cardiac notch is a notch of the greater curvature where the lower end of the esophagus meets the fundus, or rather the cardiac end of the stomach. The other notch is the most dependent portion along the lesser curvature, and this is known as the angular notch or incisura angularis. Some of the important things that I would like to mention are about the pyloric end. The pyloric end has a sphincter that is known as the pyloric sphincter. Now this is an anatomical sphincter characterized by the thickening of the circular muscle of the pyloric wall, as opposed to the cardiac end, which also has a sphincter which is known as a physiological sphincter, because there is no actual anatomical variation in the structure, no narrowing, just barometric studies have revealed that there are pressure changes along either side of the cardiac end. Hence the word physiological sphincter. Okay, let's now talk about the subdivisions of the stomach. The stomach is divided into two basic parts, which is essentially the body and the pylorus. Now, how do we differentiate between both? You find the incisura angularis and draw a line that goes downwards and to the left in such a way that it meets the greater curvature (15 centimeters distal to the cardiac end). Everything that lies to the left of this area is the body. Everything that lies to the right is the pylorus. Okay? The body can further be divided into the fundus and the body proper. The fundus is achieved by drawing a horizontal line from the cardiac notch towards the left side. So everything that lies above this horizontal line is the gastric fundus. It's important to note that the highest point of the fundus lies roughly in the fifth intercostal space. The rest is the body. The pylorus is further divided into a more dilated pyloric antrum and a narrower pyloric canal. The pyloric antrum is roughly 7.5 centimeters. The pyloric canal is 2.5 centimeters, thus making a pylorus a total of 10 centimeters long. Finally, the pyloric canal leads the first part of the duodenum, and this is the circular thickening of the inner wall of the pylorus, forming the pyloric sphincter. So to summarize, the subdivisions of the stomach are the fundus, the body, both of which are 15 centimeters long together, then the pyloric antrum 7.5 centimeters and the narrower pyloric canal about 2.5 centimeters, making the total length of the pylorus 10 centimeters. Let us now look into the interior of the stomach and understand the characteristic features. Okay, now let's talk about the interior of the stomach. If you cut open the stomach, you're going to see a number of vertical folds inside, and these are known as the gastric rugae, R-U-G-A-E. Note that these are not permanent but temporary folds that disappear when the stomach distends. If you observe along the lesser curvature, you see like a canal that is formed, and this is known as the gastric canal. The gastric canal is also known as the Magenstrasse. Magenstrasse, I don't know what the pronunciation is. And fluids tend to directly go along the gastric canal and traverse right into the duodenum. This is probably the reason why insult by alcohol usually leads to ulcers that are seen along the lesser curvature. Other than these, you're also going to see, with the help of a magnifying glass, small pits in the gastric mucosa, and these are known as gastric pits. They are nothing but openings that lead into the gastric glands, which we shall not talk about because it's a histology topic. So you've got gastric pits, the gastric rugae, and the gastric canal as the internal features in the stomach mucosa. Now, if you go from within outwards, the next layer is the lamina propria, which will have blood vessels and loose areolar tissue, and then you have the muscle coat. Now, I again want to talk a little bit about the muscle coat. If you go from within outwards, the innermost muscle is known as the oblique muscle, and it is oriented in such a direction. The contraction of the oblique muscle is what leads to the formation or the deepening of the gastric canal, as you can imagine, because of the pinching movement or the pinching effect of these obliquely oriented muscle fibers. Just outside the oblique muscle, you have the circular muscle coat, which will be oriented as such, and then finally, you'll have the longitudinal muscle coat, which will essentially be continuous with the longitudinal muscle cord of the esophagus as well as the duodenum. Right? Finally, we have the external-most layer, that is the serosa. So, once again, if you consider the interior of the stomach and go from within outwards, you have the mucosa that shows the gastric pits, the gastric rugate, and the gastric canal. The lamina propria, which is a histology topic, so we're not going to talk about that. The muscularis externa, which is further divided into the three layers: oblique, circular, and longitudinal from within outwards. And finally, the serosa, which will be lined by peritoneum, other than the lesser and the greater curvatures, which are the bare areas of the stomach. Okay, now we come to the most important and the most crucial part, and that is the relations. The relations of the stomach can further be divided into visceral and peritoneal, and I'm going to discuss in detail the visceral relations, while the peritoneal relations will obviously make more sense once we revisit the lecture on the peritoneum. Okay, whenever I teach on the chalking board, I prefer an approach where I build the posterior abdominal wall first and then start going anterior from there. So let's start by constructing the posterior abdominal wall. I'm going to draw T11, T12, L1, L2. That should pretty much be enough. Okay, we're going to go at the lower border of T11 and 2.5 centimeters to first locate the cardiac end. We're going to go 1.25 centimeters from the lower border of L1, that's the transpyloric plane, to get the pyloric end. Correct? I'm going to draw a dotted line to form the lesser curvature, and then a dotted line to form the greater curvature. Okay? Right. So we're going to go from left to the right, and the organs related to the posterior aspect of the stomach are known as the stomach bed. And the first thing that we're going to see, and we've already studied it last time, is the spleen. And if you remember, the spleen has a gastric impression, and that gastric impression is essentially related to the fundus of the spleen. Okay? Then if you remember, the spleen was related on its visceral undersurface to the left kidney, correct? So there we go. That kind of gives us an idea about the next posterior relation, and that is the kidney. Now on the upper pole of the kidney you have the suprarenal gland. We also know that traveling through the lienorenal ligament is the splenic artery. So I'm going to draw that. The tortuous splenic artery, which is entering the hilum of the spleen. Now remember, just lying inferior to the tortuous splenic artery is the upper border of the pancreas. So thus you have the body as well as a part of the tail of the pancreas that is related to the posterior aspect of the stomach. Finally, attached to the anterior border of the body of the pancreas is a double fold of peritoneum that connects to the transverse colon, and this double fold of peritoneum is known as the transverse mesocolon. Finally, attached to the distal end of the transverse mesocolon is the colon itself. And you have the splenic flexure of the colon that is attached somewhere, not exactly attached but related to the anterior end of the spleen. Get it? Finally, we must not forget the left crus of the diaphragm and the posterior inner aspect of the diaphragm. Thus, the structures lying in the stomach bed are the diaphragm, the spleen. You can immediately mention here the splenic artery. Then, because of spleen, you already know about the left kidney and the left suprarenal, so they can come next. That's your left kidney. And you can just say left kidney and suprarenal because you know that is the upper pole, right? Then, as soon as you're done with the splenic artery, I want you to remember that just line inferior to that is the pancreas. And the moment you think of the pancreas, I want you to think of its anterior border, which gives origin to the transverse mesocolon. And as soon as you're done with transverse mesocolon, you immediately know what lies to the distal end of it. It encloses the colon and the splenic flexure. So these are the structures related to the stomach bed: diaphragm, spleen, splenic artery, left kidney and left suprarenal, pancreas, transverse mesocolon, and finally the colon and the splenic flexure of the colon. So it can't be that difficult to remember. Now, let's construct the stomach on top of this. I need to invest in a little lot. Okay, there you go. Let's get the stomach again. And now, let us talk about the anterior relations. Okay, related to the upper aspect of the fundus, more towards the medial side, is going to be the left lobe of the liver. Okay, then you have the anterior aspect of the diaphragm, which I'm not going to draw, and outside of that you have the rib cage, rather the left part of the ribs, and to be more precise, these are the 7th, 8th, 9th, 10th and 11th ribs. Now I might not be able to draw them very precisely, but it might come somewhere over here. You can say 7th, 8th, 9th, 10th costal cartilages and ribs. If you want to be even more precise, you can also say the left pleura and the undersurface of the left lung. That's not usually expected at an undergraduate level. Okay, so the anterior relations of the stomach are the left lobe of the liver, the diaphragm, and the left part of the rib cage, to be precise, the 7th, 8th, 9th, and 10th ribs, along with the intercostal spaces. Of course, to seal all this off, we have the anterior abdominal wall. Okay, so these are your anterior relations: liver, diaphragm, the left part of the rib cage, to be more precise, the 7th to 10th ribs along with the intercostal spaces, and you can also mention the pleura and the undersurface of the left lung. The left pleura, also mention the left pleura and the undersurface of the left lung, and finally the anterior abdominal wall. Okay. Speaking of the peritoneal relations, I don't want to go too much into detail, but I am going to tell you a little bit about how they are attached. So you have the lesser omentum, which is essentially a double fold that is reflecting in this way. Which makes the lesser curvature of the stomach a bare area, right? So this is essentially the double fold of the lesser omentum. It eventually goes ahead and attaches to the liver, but we'll discuss all that later. Similarly, you have the greater omentum, which kind of swoops down as a double fold again. Reflecting off the greater curvature. If you trace the same peritoneum in this side, it kind of reflects off only to enclose the spleen, and that double fold of peritoneum is known as the gastro-splenic ligament, as the name suggests, and essentially encloses the spleen inside it. Finally, we have a part reflecting off the fundus of the stomach towards the left crus of the diaphragm. Don't want to get into the details of that, but that part that is going in attaching to the left crus of the diaphragm is known as the gastrophrenic. I'm sure you guys have heard about the phrenic nerve. So this double fold of peritoneum that is going towards the phren or the diaphragm is the gastrophrenic ligament. Okay, now we're going to talk about the vascularization. Essentially, the arteries, the veins, and the lymphatic drainage. Important diagram. I want you to start noting this down. Maybe you could get your notebooks out when you're watching this for the second time, not for the first time, and do this with me. Now, the stomach is actually an organ that develops from the foregut. If you've seen my first lecture, you know that the primitive gut tube is supplied by 3 ventral branches of the dorsal aorta, and the one that supplies the foregut is the celiac trunk. That's the artery of the foregut. So, since the stomach develops from the foregut, every artery that supplies the stomach essentially arises from the artery of the foregut, and that is the celiac trunk. So, I'm going to draw the abdominal aorta here, and somewhere at the level of T12L1 you have a ventral branch that is known as the celiac trunk. The celiac trunk has 3 branches, first of which is a direct branch which is known as the left gastric artery, a direct branch of the celiac trunk. The other is the highly tortuous splenic artery, which we studied in the posterior relations of the stomach, remember? And that ends up supplying the spleen, but it also ends up supplying a few short branches that traverse all the way towards the anterior and posterior aspects of the gastric fundus, and these are known as the short gastric arteries. Okay. The final branch of the celiac trunk is known as the common hepatic artery, which further splits into the hepatic artery that goes towards the liver, and the gastroduodenal artery, which, as the name suggests, goes towards the pyloric end of the stomach and further towards the duodenum. So the right gastric artery could either be a branch coming from the common hepatic artery or sometimes the hepatic artery proper. There's variations in that. This is your right gastric artery. Finally, the gastroduodenal artery along the greater curvature lower aspect gives an artery that is known as the right gastroepiploic artery, and the splenic artery also gives a branch that travels low, that travels inferiorly along the greater curvature, and this is known as the left gastroepiploic artery. Okay, so once again, the stomach is supplied by the left gastric artery, a direct branch of the celiac trunk, the right gastric artery, a branch of the hepatic artery proper, or sometimes arising from the common hepatic artery, the right gastroepiploic artery, a branch of the gastroduodenal artery, the left gastroepiploic artery, a branch of the splenic artery, and finally short gastric arteries, which are also a branch of the splenic artery. The word epiploid over here is pointing towards something known as the epiploid foramen, which we shall study in the peritoneum. Okay, so now that we're done with the arterial supply, let's talk about the venous drainage. So the venous drainage is slightly different. The left gastric vein, yes, the right gastric vein, yes. Both of these are direct tributaries that end up emptying into the portal vein. Now the portal vein, which we shall study in detail at some other point of time, is a vein that is formed by the union of the splenic vein and the superior mesenteric vein. Now the union happens at the posterior aspect of the neck of the pancreas, and we shall study that when we do pancreas, but here somewhere is the union of the superior mesenteric vein and the splenic vein to form the portal vein. The left gastric vein and the right gastric vein are direct tributaries ending up into the portal vein. The right gastroepiploic vein ends up emptying into the superior mesenteric vein. Okay? The short gastric veins and the left gastroepiploic vein both end up into the splenic vein. Okay? So once again, the left gastric and the right gastric veins end up into the portal vein as direct tributaries. The short gastric and the left gastroepiploic veins end up into the splenic vein, while the right gastroepiploic vein ends up into the superior mesenteric vein. Another important thing that I want to now tell is the pre-pyloric vein of Mayo. The pre-pyloric vein of Mayo, which does not have a corresponding artery, and it serves as an important landmark for the surgeon to identify the pyloric end of the stomach on the operation table. Okay, very important, the lymphatic drainage of the stomach. Now, gastric carcinoma spreads by the lymphatic route, so it is essential to understand the anatomy of the lymphatic drainage of the stomach, especially for onco surgeons. Now, at an undergraduate level, we're not going to go into too much details, but we need to be aware that the lymphatic drainage of the stomach can be divided into 4 zones. This is how we derive the zones. You draw a line along the vertical or long axis of the stomach, which divides it into a right 2/3 and a left 1/3. Okay? Now, the larger right area you divide into an upper 2/3 or roughly 3/4 and a lower 1/3. The area that lies here is zone number 1. Now you go towards the left narrow aspect and divide that into an upper 1/3 or 1/4 and a lower larger 2/3 or 3/4. This is area number 2. This is area number 3. And this is area number 4. Now, area number 1 drains into what are known as the left gastric nodes, and these lie along the lesser omentum. Area number 2, and these are the most important for gastric carcinoma, are known as the right gastroepiploic nodes, since they lie along the vessels of the same name. Okay? And as you farther go distally, the ones over here are known as the pyloric nodes. Zone 3 drains into what are known as the pancreatico-splenic nodes, which are, as the name suggests, in close relation with the tail of the pancreas and the spleen. And finally, you have zone number 4 that drains into, you can see that this is closer to the liver. So these are the hepatic nodes, and some of them are also known as the right gastric nodes. Okay, so the right gastric and the hepatic nodes drain from zone 4. Finally, all of these eventually drain into the celiac group of lymph nodes. Okay, So once again, zone 1, left gastric nodes. Zone 2, right gastroepiploid and pyloric nodes. Zone 3, pancreatico-splenic nodes. And zone 4, hepatic and right gastric nodes. And all of these eventually drain to the celiac group of lymph nodes. Okay, now let us study the innervation of the stomach. Now, any viscera is essentially innervated by the autonomic nervous system, which can be classified into sympathetic and parasympathetic. Okay, now please note that the sympathetic nerves travel from the T6 to T10 spinal segments via the greater splanchnic nerve and the celiac plexus to end up supplying the stomach. Now, what does the sympathetic system do? A, it is vasomotor, which means it will constrict the blood vessels related to the stomach. B, it is motor to the pyloric sphincter, which means that it will contract the circular muscle and lead to shutting down of the pyloric sphincter, thus delaying gastric emptying. So when there is sympathetic stimulation, the gastric motility is inhibited and the gastric emptying is delayed. Okay. Other than that, also remember that the sympathetic system carries the pain sensations from the stomach wall. The parasympathetic system essentially is the left and the right vagus. Now please note that won't discuss details, but during embryological life, the developing stomach rotates 90 degrees clockwise so that the left vagus ends up supplying the anterior part of the stomach and the right vagus ends up supplying the posterior part of the stomach. Okay? Now, remember that vagal stimulation will have exactly the opposite effects, so that there is going to be increase in gastric motility, that is peristalsis is propagated. It's going to be encouragement of gastric emptying and the relaxation of the sphincter. Basically, vagal activity is friendly to gastric motility. Secondly, it is secretomotor, which means that all the secretions that happen in the stomach, for example HCl secreted by the parietal cells, happens so by vagal stimulation. So if you were to somehow inhibit vagal stimulation, the acid secretion will actually be reduced, and this can be used in the treatment of acidity, which we will study in clinical anatomy. Anyway, so the left vagus supplies mostly the anterior aspect, and these are the branch. Firstly, it gives the hepatic branch, which is on its way to the liver. The second branch is the celiac branches, and finally you have the anterior nerve of Lackarche, which is an important nerve from the point of view of vagotomy for the treatment of acidity. The right vagus gives branches to the fundus, which are known as the nerve grassi. Celiac branch is similar to the left vagus. And finally, the posterior nerve of Lackarche, which supplies most of the posterior aspect of the stomach. Okay, lastly we are going to speak about the clinical anatomy of the stomach. Firstly, I want to speak about something that is known as the Drawbay's space. The Drawbay's space is a space that is intimately related to the fundus of the stomach, and because there is usually air in the fundus of the stomach, it gives a tympanic note on percussion. Drawbay's space has the following boundaries. The lower margin of the left lobe of the liver on the right side, the lower margin of the left lung forming the superior border, the lateral aspect of the spleen forming the left border, and finally the left subcostal margin forming the inferior border, and this is where the fundus of the stomach typically lies. So if you focus in this area, you get a tympanic node. If the node loses its tympanicity, it means that there could either be a problem in the pleura, because that's where the pleura lies, right? So it could be a pleural effusion. It could also be due to splenomegaly. So basically, the lack of a tympanic node in Troby's space could point towards a pathology either in the spleen or the lung. The next thing that I want to speak about is the gastric carcinoma or the stomach cancer. Now, as I said before, it is spread by the lymphatic route, so you need to understand the lymphatic drainage and the different zones really well. I also want to speak about the Virchow's nodes. Now, the Virchow's nodes are the left supraclavicular nodes, and they are the first ones to be enlarged in case there is gastric carcinoma. Okay, and this sign is known as Troisier's sign. The lymph nodes are enlarged because the infected lymph travels through the thoracic duct. You should study all that in thorax, but that's the Troisier's sign. Next, I want to speak about vagotomy. Now, I already mentioned before, since the vagus is secretomotor, cutting the vagus would lead to lesser acid production and thus solve the acidity problem in a patient. However, it comes at a cost. You're going to have reduced gastric motility because I also told you that the vagus is stimulatory to peristalsis, right? Because of reduced gastric motility, you can have other problems. What we can do is undergo what is known as a truncal vagotomy, which is not the best thing because if you cut the trunks, you're going to have a loss of the other functions of the vagus as well. You can also go for a selective vagotomy where you can spare the celiac and the hepatic branches, thus maintaining their function, or you can go for a highly selective vagotomy where you can only cut the anterior or the posterior nerve of Latarjet, thus reducing the overall amount of damage that is caused due to vagal inhibition. Okay. Finally, I'm also going to speak about the referred pain. And just remember that the referred pain of the stomach is felt vaguely in the epigastric region, and that is because the segments that supply that area of the skin are also supplying the stomach. Sympathetic pain afferents. Remember T6 to T10. I'm not going to speak a lot about peptic ulcer because that will probably come in physiology. But if I were to briefly talk a few things about it, I would say it is an imbalance between the production of acid and the protective factors that prevent the stomach mucosa from getting auto-digested. So there are lots of factors which prevent that from happening. When there's an imbalance and there's more predominance of the acidic activity in the stomach, you get peptic ulcers. Alcohol could be one of the reasons, but again, don't want to get into too much of that in anatomy. Okay, thank you so much for listening, and I'll see you in the next one, that is duodenum. Bye.